Also, thank you very much for this, for the invitation to present here the data of the Actifcare project. These are actually the first data, fresh data, and it's really impressive here on this wonderful symposium conference also to see how many people are still attending the last session of this conference. So I think a lot of nationalities do have dementia strategies at this moment, and one common factor of all these strategies is the attention of the underlining of the importance of an early diagnosis. An early diagnosis, especially a mean to get easy access to services. And in the report of Alzheimer Europe of 2013, the benefits of an early diagnosis in terms of benefit from care and support service has been summarized, which you can see here. Benefit, caregivers receive timely support, less anxiety, better chance of benefiting from treatment, living, financial, legal matters, etc. More time to plan for the future. But I think this is in a way a bit theoretically, because in practice we also see there is a mismatch. And that we see that a lot of people with dementia actually do not use the services that we think they might benefit from. And we know from literature, from our own studies, but also studies from Henry Brudetti, for instance, that actually about 50% of the people with dementia do not use the services that were designed for them. And those who it's kind of a contradiction in terms, and those who felt that those who used actually the service felt also that they had no choice for this. So that it was very emotional process, and it's not really rational decision making. So there's a kind of paradox. The strong emotions involved, difficulty accepting dementia, progressive nature of dementia is important, and also the reliance on surrogate decision making, meaning that they postpone let others decide for me, I don't know, because I'm not well informed or whatever. And there's also a paradox in it, so people tend to reject the services and the access to services in the early stages, but later on they might regret, and a lot of people say to us, we felt that we could have used and benefited more early from these services. So, and this is exactly the what we did in the Actifcare study. I think I have also not a very good version of this, my presentation, but I do mine. Let's go through it. And I also want to thank the consortium for this. I don't know how many people from the consortium are still left, but it was really fun to work with, very high-skilled experts in the field. I think they were European best leaders in the field, and it was also a great, effective consortium with nice people with whom it was a really pleasure to work with. And the aims of Actifcare was, in fact, to better understand the reasons for this mismatch between the needs and the use of these formal care services. And we did it on several levels, organization and policy level. We had the level of persons with dementia and the caregivers, family caregivers. And also we want to examine the level of costs and consequences. And at this moment, we analyzed the data from this work package. We started to analyze the data results from this work package, and we did not have a full oversight, so I cannot present data from the health economy part. But they are, of course, very interrelated, and in the end, we needed the best practice to formulate it. And we hope to do so within several years. We use a mix of methods. We use qualitative and quantitative methods. The qualitative includes literature reviews. We have focus groups and expert consultations with policymakers and people from the insurance companies. It is also included to have a cohort study. We include 50 diets per country. And we do a cost consequences analysis, and this is based on the theoretical Anderson model, which is a kind of theoretical model to explain and as a kind of framework to see what factors are involved you see this model here, in the use of care. It's not only if you have a disease, you use a certain service, but it also depends on personal characteristics, enable resources, but also personal health choices, use of services, and the healthcare system altogether. I won't go into the detail, but share with some data here. So which socioeconomic and cultural aspects influence the access to formal care? This was part of the first literature study done by the German team, led by the German team, I must say. This is not, okay, I think. I do think this is the wrong presentation as well, like you, Alexander. But in a way, there were several factors identified, like age or gender. Female tend to postpone the use of services more often than males. Gender was, ethnicity was important. Also, the attitude and belief of the what people thought about the access of services was also important, and all they together, they led to a report with the on barriers and facilitators. We also used focus groups. A lot of focus groups were held, actually 55, encompassing 261 people of different levels, healthcare professionals, but also individuals living with dementia, and also informal carers, and they were done cross-national in all these 8 European countries. And we also tried to find the common denominators, but also we want in the future see what are the differences that work and did not work so well. Different system levels, and here you see some data of the attitudes and belief in formal carers. In all groups was a predominantly negative atmosphere, so it was about the stigma of dementia. Caregiver was seen by informal carers as an obligation. Relinquishing care was seen as a personal failure. And to quote someone, to get someone in, I would feel as if I was pushing him away, which was a quote from an informal caregiver from the UK. Attitudes or belief of people with dementia. The threat also, it was seen as a threat to individual desire to stay independent, and it should be avoided at all events. And they wanted to be more involved in decision making, and also they felt there was a limited recognition of what they really demanded. And this was also illustrated, I think, by a quote from a person with dementia from Italy. They think as worse than children, but it's a mistake because we always carried by ourselves until now, and we are doing even now. Or a person with dementia from Norway, someone else, the children must have found out what I needed. And also from the healthcare, they also reported that the perspective of people with dementia were hardly taken into account, and this led also to a lack of insight, but also to a somewhat negative attitude. For instance, that because of the media, somewhat net, and even services are so much promoting independent living, it makes you feel guilty, like you feel basically a lot of guilt. I think these are very important quotes also to get more insight from what factors do play a role. So this is a summary of all these factors, attitudes and belief, knowledge regarding dementia, the knowledge regarding dementia. People thought that healthcare professionals did not have the adequate knowledge about the dementia and also the available service and what could be of benefiting them. Professional nursing support was a threat to independence. Healthcare professionals themselves may function either as a barrier or as a facilitator, and in several instances also the need of a constant contact person was mentioned, the importance that could be a major facilitator among those sectors. As a second part, we had a cohort study with quantitative data. with diet, with a person with dementia. We focused not on the very early stages, but somewhat on the middle stages, in the stage that one might consider to need services and get access to some service systems. So in the beginning not, but in the year there was a clinical judgment that it was likely to be considered for 1 year. And currently we have 453 diets completed now, with 2 assessments, 3 assessments, one a baseline, 6 months, and 1 year follow-up. We just collected and finalized the data set and cleaned the data set. We are still analyzing, but we do have, and I can present some provisional results. You see the inclusion, it's more or less in the same in all countries, and here you see the characteristics of people living with dementia with a Mini-Mental score of 19, really reflecting the middle stage is not very early, so this is really the stage that people might consider to use services, or whatever, informal care. We also thought that there was a discrepancy upon, these are the numbers of unmet needs, was a discrepancy among raters. It depends whether the person with dementia or the caregiver is almost double the number of needs, unmet needs identified, and even the Actifcare researchers identified even more needs. And these are the types of needs, the characteristics of needs. So people with dementia felt they need more company, more information, also more daytime activities. And the informal carer thought more or less the same, but in another order and another frequency. And the same arose from the Actifcare researcher, the needs in the same domains, but also identified the needs in psychological distress and finances. Also, the budget was a problem. And these are the factors: dementia severity, hours spent to care by a formal carer, numbers of both met and unmet needs, the living situation, the education, age of the person with dementia was important. Also, the carer's age, education, and sense of coherence was mentioned, identified as an important factor to enhance the access to formal care. We also had kind of exit interviews with every individual participating in the study, and we had several questions that we posed and asked to reflect in retrospect what, for instance, did formal care actually help in staying independent? And it is also, I think, significant that most people find it difficult to answer this question, because they found it a difficult question. In a way, they found it also a kind of limitation. Your personal freedom and privacy was challenged in a way, but it also was enhancing in the way that you could do as much, you can do more for a longer time, possibly. And there was also a kind of change of attitude. In the beginning, it seems like a limitation, but when formal care was in place, most people thought that there was, in fact, an enhancer. Other question was cooperation with the healthcare profession experienced as helpful? And many people thought there was still a lack of knowledge, also a lack of knowledge on dementia, but also a lack of knowledge on the services and what they could offer. And they advised more to start with the personal needs of the people instead of just mentioning what kind of services are available. A good explanation in the beginning is necessary. People often felt that they lacked such a good explanation. Taken to the account, needs into account when finding the right type of care, and the contact person again was also mentioned, who is easy to reach. And also start gradual, not immediate, and also a gap between day centers and nursing home admission was also measured as it should be more gradual in a way. Other question was, do you have advice for healthcare profession of finding an easy way through this access to care? And it was advised that professionals should acknowledge the problems more and the emotions of the carer. They should not be patronizing. Professionals should be trustworthy and respectful. And also it was an advice for informal carers, the family carers, be proactive, be a critical consumer, and be proactive in the sense that you anticipate what could happen and be informed and try to be informed as much as possible. So we also had a health economy part. I cannot just mention, but just to see there were quite some difference among countries with regard to the costs of 1 year follow-up, and sometimes these also pertain to hospital admissions. They were very expensive, and perhaps if the access to care is not very efficient, if you can make it more efficient, you can also avoid hospital admissions. And then it might be more effective. And of course, we also identified that it is more expensive to that needs are actually met, because that you have to do something. But in a way, we will also look at the ratio between the extra costs and the extra quality of life of the participants. So these are some provisional conclusions. There is some room for improvement, I think. Actually, it's still, there is lack of information. It was still perceived as a kind of stigma. We need to combat more all the stigmatizing aspects of the access to care. The need for a carer manager across care sectors. Also be proactive, better acknowledge the emotional problems, discuss guilt and shame, not be pushy or patronizing, and also be trustworthy and respectful. And also a need to have more services in rural areas. This was so far the results from this, I think, potentially very important project, which studies a kind of understudied aspects of care systems. And we hope in the next months to identify the best practice strategies and to improve the effectiveness and the efficiency of these access to European dementia care systems. We want to gain more insight in spillover effects, and also we want to compare the care systems across countries, and especially also learn from one country to the other and see what we can see on a European level as the best practice altogether. So I come to an end. I'd like to thank the whole team. I think it was really a wonderful team with work, and we're looking forward to continue working with them. And also we want to thank all the national agencies who supported this in a really joint program. Thank you very much.